and I'm gonna spend maybe the next half hour or so just going through an overview of COVID and COVID safety for people who do what you do on a daily basis. I hope we'll have time for some questions, and I hope we'll have lots and lots of questions. All right. So how do I advance? So a little bit about, so COVID-19, when we talk about COVID-19, it's the illness that is caused by the virus SARS-CoV-2. You'll see that on some of the slides, but the slides do make that distinction, although in general terminology, we use COVID-19 to refer to both. The virus is actually SARS-CoV-2. And in the US, this was updated yesterday, almost 30 million cases with almost 550,000 deaths. I don't know if you can see the right side of your screen, but the numbers for Philadelphia are there. And out of 1.6 million tests, we've had 120,000 cases. Yesterday alone, 276, and about 3,000 deaths. So this is what it looks like in the US writ large. The states with the highest number of cases, California, Texas, Florida, and over here is, I think, Illinois. My geography isn't the best. And deaths also follow that. But the highest number of deaths also include Pennsylvania and New Jersey. So, and hospitalization rates, people who are 65 and older account for the highest rate of hospitalizations. But the good news is those rates are starting to come down, although they remain high. And you see that reflected here by the slide. It's broken down by race and ethnicity. And in the 65 and older group is where you see whites having the majority of hospitalizations. In other groups, that may not be the case. Hispanic groups have also been impacted. And you have to remember that these blocks just show the percentage of people getting hospitalized when you compare to the percentage of the general population that is made up by, say, Hispanics or Blacks. This is out of proportion, an outsized disproportionate share that is among people hospitalized for racial and ethnic minorities. So this is how it gets transmitted. Aerosols are tiny, tiny particles. You may be able to see them like in smoke, or you may not be able to see them like in dust, right? And these aerosols can hang in the air sometimes for hours after they're generated, and that is one way of transmission. And then there's droplets. Those are much bigger than aerosols. They may be expelled into the air and then drop right to the surface. And so that's why it's contact or droplet. So when it drops to the surface, if someone comes by and touches the surface and then touches their mouth, nose, and so on, that can be transmitted that way also. And then you can see it on the surface there. The virus has been found in urine and feces of people who have been infected, but from very, very few specimens. So this is essentially our current understanding on the way that this virus is transmitted. And just for your own kind of FYI, this slide, and I'll only look at the top row if that's okay with you, shows how long the virus hangs out on different specimens and in the air as an aerosol. You see that as an aerosol, it seems to hang out for at least 3 hours, or at least it's capable of hanging out for at least 3 hours with very, very little drop off in the amount of aerosol there is. On copper surfaces, it doesn't last that long. It just drops fairly quickly, and then it's down to very low amounts. On cardboard, a little more slowly, stainless steel, yet more slowly. And on plastic, it can hang out as long as 60 hours or so before it drops down to close to zero. So as you're handling various surfaces, I presume you all use a lot of cardboard. Just be aware of that. So the way it's transmitted is somebody who coughs, sneezes. Singing is huge for those of you who are affiliated with churches, although you may not be having services, live services now. Talking or even breathing. And the more virus somebody has, the more likely they are to transmit. Now, after somebody gets sick, about a week, 9 days after they start to get symptoms, you rarely then find virus in their respiratory samples, especially for those who don't get very sick to begin with. And we have very little evidence showing mother to child transmission, and that's the good news on this slide. So when somebody has symptoms, before they get symptoms, when do people transmit? So in one study, it was found that people were more likely to transmit just before their symptoms started or within 5 days after their symptoms started. So just before to 5 days after. But another study in another country showed a little bit of a difference. In Singapore, only 6% of infections were from people who before they got symptoms, whereas in China, they found that 44%, almost half, happened just before symptoms appeared. That's why our guidance say to utilize our protective equipment kind of in general, just not just around people who appear sick. This is an interesting study. So this is a restaurant. I know there's some states that have opened up to indoor everything, right? And this is a cautionary tale. This is a restaurant where one person, patient 0, you see that person is circled there on the right, happened to have COVID. Nobody knew it at the time, right? And it turned out that just from this restaurant experience, all the people in red, 10 of them got, 9 of them got COVID from this one person. Now, the person who had COVID, from her table to table B, they had a 53-minute overlap. So both tables were there for 53 minutes. And then with A and C, there was a 75-minute overlap. But nobody else and none of the servers got COVID. And it's believed that that happened because there wasn't that much time spent around this person who had COVID. So there were 15 other tables, nobody else got COVID, and none of the waiters got COVID. So in addition to distance, the time that you spend around somebody who may be generating infectious virus also matters. So crowded and closed spaces can facilitate transmission, especially if people are in there for a longer duration. And here, you just see the arc of the graph. The more distance, the less likely transmission is. By the way, these are, I think, European and Asian figures, so the distance is in meters. 6 feet is just a little bit less than 2 meters. And so it's much, much better than 0 feet. But the further out you go, the less the chance of transmission. What about face coverings? Very interesting. So surgical masks, any kind of face mask use resulted in large reduction in infection, down to 15%. So from 100 down to 15%. That was better if the mask was an N95 versus the disposable masks or the layered cotton masks. But the disposable masks and the layered cotton masks also work well. The N95 just works better. And so you find that being used in healthcare settings where people come up close to examine patients who may or may not have COVID. So on the right, in a study of children and adults who were sick, wearing disposable surgical face masks, for people who wore the face masks, there were 0 samples that had virus detected, whereas for people who were not wearing face masks, we found virus in 3 of 10 samples. And similarly with aerosols, 4 of 10 for people without face masks and 0 of 11 for people. So the bottom line is the masks work. They work best to protect other people from us, but that's the way we prevent spread in a community. So this slide summarizes it. Identifying, quickly testing, isolating, and treating people who test positive, quarantine for close contacts of people who test positive, washing hands often, soap and water. If we don't have access to water, hand sanitizer until we can reach water, maintaining what we're calling a social distance. About 6 feet is what we're using, but remember, the further the better. Wearing a face cover in public, and practicing respiratory etiquette, of course, if you're sneezing into your elbow and so on, and disinfecting frequently touched surfaces regularly every morning, depending on what exam room I'm using. First thing I do is put my bag on my chair, wipe down my keyboard, mouse, phone, desk, chair arms, door handles, everything. And I've been doing this since for a year now, essentially. And then avoiding crowds. I go to the Reading Terminal Market sometimes, and on Saturdays, and on some days, all I do is open the door and peek inside and see how busy it is. And if it's busy, turn right around and go back home. And these are on the right, the solutions that have been shown to be active against the virus: 62% alcohol or higher, hydrogen peroxide, 0.5%, sodium hypochlorite. There are some other solutions that have been used, the chlorhexidine, the benzalkonium chloride. Those are less effective. They have some efficacy, but less so. So we talked about that. Now, when physical distancing is not possible, especially for people who are caring for people who are older, people who have other medical conditions, in confined spaces, railway cars, other confined spaces with poor ventilation, it's important, even more important, to have the nose and mouth covering. I see a lot of people coming in with the covering sitting right under the nose. It's helpful, but not helpful enough. So what about herd immunity? We've heard a lot about it. It's when there are enough people in a population who are immune, then that indirectly protects some other people who may not be immune, just because a sufficient portion of the population is immune. So enough of infections get blocked that it may not get to other people who may not be immune. And the threshold is the point at which that happens. What is the proportion of population that needs to be immune to have herd immunity, and so prevent transmission to other people who may not be immune? Here's the thing with herd immunity. Oftentimes, when we hear about it in discussions about should we let people get COVID just so we have enough people who have some immunity? That works for some conditions that are not as lethal as COVID is. So if the mortality rate is 1 in 1,000,000, sure, let people get the virus and get a lot of people infected, especially if it doesn't cause a lot of illness also. But if with a disease like COVID, trying to get to herd immunity by allowing people to get COVID is a non-starter, because that means that you're going to have massive numbers of death associated with that effort, right? Especially with COVID, where the disease seems to be more lethal in certain populations with the highest risk of mortality. So the other side of the coin is that some of our non-pharmaceutical interventions, wearing masks, hand washing, social distancing, etc., also decrease the ability to establish herd immunity. And that leaves us with the best option of reaching herd immunity being vaccination. Enough people in the United States get vaccinated, and there will be a herd immunity that protects even the hopefully few people who do not get vaccinated. So vaccination is our way to herd immunity without massive loss of life. Very quickly, on racial demographic disparities, these data from New York City, looking at the cases, hospitalizations, and deaths, and you see that Black and Hispanic populations have the highest rates of cases, hospitalizations, and deaths. You also notice that the disproportionality actually increases for Black folks from cases to hospitalizations and deaths. That means hospitalization rates, death rates are higher for Black folks than for some of the other races and ethnicities here. Looking by poverty level, you see a similar pattern. People in people at the very deepest level of poverty are the ones bearing the brunt of this epidemic. And we can talk about why, of course, both for poverty level and also for the racial and ethnic disparities, for cases, for hospitalizations, and for deaths. And so achieving a herd immunity is something that would be protective, say, for the homeless person who may come to one of your soup kitchens and who, for whatever reason, does not get vaccinated but may be spending the night in a shelter where they may be exposed to other people who may or may not have COVID. A herd immunity may protect somebody like that, some of the most vulnerable. So this is just a list of factors believed to influence the racial and ethnic minority group health, because we're all aware that COVID isn't the only one that disproportionately affects racial and ethnic minorities, right? Living and working conditions, health and access to care conditions, and in the bottom bullet on the left, multi-generational households and limited space. So my patient who every night goes back home from working, but goes back home to her sister's home where she lives and where she sleeps on one of these lean back, lazy boy couches, I guess. That's where she sleeps, with everybody in the house coming back and forth, and who knows where everybody has been that day, right? So what can we do? Some of the things we're talking about, but engaging with organizations that are trusted by the communities that we want to reach and that we say we want to work with, providing some telehealth options. Everybody seems to be doing that now, except you all can't. You're in the business of distributing food, right? So you have to distribute it. And so all of those recommendations become more important for you. Ensuring that people are aware and respectful of different cultures. I know I don't have to tell you that. And then adapting public health recommendations to community circumstances. I'm not saying that to you as much as I'm saying it to myself because I work in public health, right? And you all know what the symptoms are: headache, loss of taste, loss of smell, cough, sore throat, and people may describe all of these differently. Dry throat, tickle in the throat, different terminology for it. Shortness of breath or difficulty breathing, that tends to be what sends people to the hospital the most. Fatigue, muscle aches, body aches, fever, chills, and some people get more intestinal symptoms, vomiting, diarrhea. The symptoms 2 to 14 days after exposure to the virus. And then there are some people who get none of these symptoms at all. The symptoms also may be a little bit different by age and by sex. For example, older patients tend to have more fever, loss of appetite, diarrhea. Younger patients tend to have more symptoms above the neck. And women have more loss of smell, headache, throat pain, fatigue. Men are more likely to have a cough and fever. Okay. The other thing to notice is that from the first symptom to death can happen as fast as 14 days, but in older patients can happen even faster. People 70 and older can happen as soon as 12 days. Just think about that. Whereas for people less than 70 years old, the average is about 20 days. And I'm not saying that either one is better than the other, but just think about that. Think about somebody who may be feeling well one day, the next day may start having symptoms, and a week and a half later, maybe no longer with us. This is what families are going through. There are some long-term effects that we're just beginning to understand for the lung, for the heart, for the neurologic system. And the reason is that the receptor that the virus kind of locks onto to get in the cell is not only in the lung, it's on several different tissues. But included in this list of long-term effects, post-traumatic stress disorder is huge. Depression, anxiety, even after 6 months, still considerable. And so it's something to look out for. And then a word about variants. Can't have a discussion of vaccines without variants. The different colors just point to the diversity in different variants in different parts of the world. So if you just look at the US, we have most of one kind of variant, but we have a good portion of the green and purple and a couple of others too. And we are actually not testing a whole lot for variants. So imagine what we'll find if we did a lot of testing. We've all heard about the UK variant. It's been around since September. And the worrying thing about it is that there's been an association between a rapid increase in COVID-19 cases and the emergence of this new variant. Now, in the US, now where did I have that? Okay, outside of the UK, different countries now, as of December 29th of last year, there were 467 cases reported. As of about a week ago, there were 3,283 cases reported in the US. So despite our limited testing for variants, we're seeing a growing number of this particular variant, not just here, but around the world. And then there's the South Africa variant, which also has data to suggest that it's much more transmissible than other variants. And why are we concerned about variants? It can lead to faster spread. It is possible that it may be harder to identify them by the standard diagnostic tests we use. There may be decreased efficacy of some of the treatments that we use for people who are very sick with COVID. And there's always a possibility that they can escape the immunity that we're generating through natural infection or through vaccines. Now, that is unlikely because the vaccines, as well as natural infection, induce a response that is sort of, it touches the virus in different ways. So it's unlikely that one change to the virus will evade that, but that is something that we need to monitor very, very closely, because there is some evidence that the kind of mutation that the South Africa variant has may be able to escape immunity acquired from natural infection. Now, that is highly concerning. Now, the vaccines, some of the vaccines have been tested with that particular strain, the South Africa strain, and have shown good efficacy. So as far as we know, the vaccine, and this is the J&J vaccine that has been tested, is good against the strain, but it's something that we need to watch carefully. And we know that about the J&J vaccine because some of the trials were conducted in South Africa at the time that this variant was on the rise there. So we have data with that variant with J&J. And here are all the emergent variants of concern. One in the UK, we talked about South Africa, we talked about this one in Brazil. UK and South Africa appear to be more transmissible. And this is kind of an overview of the vaccines, which at the time had not been approved yet. J&J has now been approved. The efficacy here has been shown to be 72%. And you see that in South Africa, it was 57%, even though almost 100% of cases were due to the variant. And it offers complete protection against hospitalization and death. I know that the mRNA vaccines, the Pfizer vaccine and the Moderna vaccine, which is the one that I got, tout 95%, 94% efficacy numbers, and people see 72% and think that maybe it's less efficacious. When it comes to the bottom line, protection against hospitalization and death, all three of them offer complete protection as far as we know now. And so it's important to remember that. Now, the Novavax vaccine, it's a different mechanism. It's a protein-based. The Johnson & Johnson is adenovirus. It's DNA in an adenovirus coat, but the adenovirus does not take hold in the body once it's injected. The Novavax vaccine is protein-based, and the mRNA vaccines are similar to the Johnson & Johnson vaccine in the sense that it's introducing a genetic instruction to the body so that the body can generate a response that can be called on if the body comes in contact with the COVID virus, right? But Johnson & Johnson uses a DNA to transmit that information, and the mRNA vaccines use RNA to transmit that information. The mRNA vaccines also are not enclosed in a virus particle. Johnson and Johnson is enclosed in an adenovirus particle. It is not a virus particle that causes infection in the body. I'll be happy to take questions about that if there are any. Now, this is again illustrating herd immunity and showing that for COVID-19, the estimated vaccinated proportion needed for herd immunity is between 60% and 72%. What is our population, like 300 and what, 30 million? I can't even calculate 60% of that, like 200 million and change need to be vaccinated at a minimum for herd immunity. So we have ways to go. So with all of this information, I sit with patients day in and day out and recommend the vaccine and answer all the questions. And sometimes after all of that, there is still some hesitancy to take the vaccine. And, you know, I can tell you anecdotal reports of what I hear are the reasons for that. But this chart on the right and at the very bottom of the right-hand side, you see the reasons in the United States. So people are concerned about side effects. And what I usually tell people about that is that, you know, there's a distinction between side effects and the vaccine working the way it's supposed to. Because the way the vaccine is supposed to work is by stimulating our immune system. And whenever you stimulate the immune system, there are some symptoms that come along with that. Fever, chills, muscle aches and pains, fatigue. So I'm not sure that's a side effect as much as it is the vaccine working the way it's supposed to. And for those people who get those side effects, 24, 36 hours at the outset and it's gone. It happens like magic. It's like 1 minute it's there, the next minute it's not. And it's gone. And that pales in comparison to what could potentially happen if that person were to get COVID. Another reason people are concerned about the fast approval of the vaccine. We've known about this virus for a little over a year, and already we have 3 vaccines. I understand people are concerned about, but the way to look at that is that we've known in the scientific community for decades that coronaviruses could become a real problem. You all may remember SARS, you all may remember MERS, although we didn't see much of that in this country. And these are all coronaviruses. And we know the reservoir of coronaviruses that may be in bats, for example. And we know there's a potential that every now and then we may see some infecting humans. And so for more than 10 years, for 10 to 15 years, the National Institutes of Health has been supporting research into coronaviruses. So way before COVID, we knew that the spike protein would be the best target for a vaccine. And so when the Chinese published the genetic code of this particular virus, scientists around the world were off to the races, but they were off to sort of the last quarter of the race. The rest of it had been run already, which is why it appears so fast. The mRNA technology had already been developed, it just hadn't been used. And so it's not as fast as it appears. Some people are afraid it's not effective. Some people think they're not at risk. And then some people are generally against vaccines. So these are some of the reasons what I hear from patients. Patients are concerned that the vaccine may be a way of putting a chip in their body, for example. Patients have told me that they hear that the vaccine could make them sterile, except the woman who told me that was 62. So my response was, what do you care, right? And And I've heard different things that the vaccine could give them the virus, that people have died after taking the vaccine. I've heard different, but these are things that are addressed one-on-one with patients. And then people may think that because they're on this medicine or that medicine, they can't take it. Or people may think that because they have HIV, we don't have a lot of information on HIV and the vaccine. We actually do have some data, and if there's some interest, I can go into that a little bit. And with that, I don't want to sort of use more time than I've been allotted. And so I will stop sharing